and good morning, everybody. I'm really excited to be talking with everyone today about the future or lack thereof of the lecture. This has definitely been a topic that has been near and dear to my heart this year as education chief, and the irony that I'm giving a lecture on this topic is not lost on me. So I have nothing to disclose. By the end of this talk, you should be able to describe the basic principles of adult learning theory, apply adult learning theory principles to postgraduate medical education, and you should be able to formulate an approach to improving formal didactics. I'll start today by hopefully convincing you that this is an important and relevant topic. We'll then take a quick historical look at the lecture within medical education, and then I'll give a brief overview of some basic principles of adult learning theory. And I'd just like to make a disclaimer that I am a product of this residency program, and this talk is in no way a criticism of this program or our didactics. Rather, I hope that we can take a critical look at postgraduate medical education. And just as we take an evidence-based approach to our medical decision-making, we too can take an evidence-based approach to the way we teach and the way we learn. I hope to then leave you with several practical tools and methods for improving lectures based on this data. And we'll end by talking about some barriers that still remain and future study that's still needed. And so I'd like to just start by posing a couple of questions. And I was hoping to do this through Poll Everywhere so that everybody could participate, but unfortunately I wasn't able to get that to work. So if a couple of faculty maybe just want to unmute and answer this question, I'll start by asking you all, what do you think is the most effective teaching method? And I've put up a few options here, but if there's another didactic method you've used that you find particularly effective, please feel free to mention that as well and just let us know why you think that's the most effective method.
Case-based discussions.
Okay.
I would echo that, Jordan.
I would as well.
Can I say B through D?
Yes, multiple choices there.
Yeah, small group, case-based discussions with multiple choice questions, yeah.
Okay, so it seems like nobody has chosen didactic lectures, slide presentations. And I'd like to pose a similar question to residents. What didactic format do you most prefer? And again, the same choices are here, but you can feel free to pick a different option that's not listed.
I would say case-based discussions in small groups is probably my favorite.
Great.
Well, there's a difference between favorite and effective.
And effective, yes, Dr.
I would say B and D.
Okay. So a lot of votes for case-based and small group learning, especially. Okay, great. So we'll see if anyone's thoughts change, I guess, at the end of this talk. So first, why is this important? Well, the ACGME requires structured didactic experiences that cover all aspects of neurology. And every year, the residents are required to indicate on the ACGME survey their level of satisfaction with the program's didactic offerings. Certainly for the residents who are listening, I'm sure you're all no doubt sick of my constant new conference reminders, but you all know that didactics are an essential part of our residency education. And for the faculty, many of you dedicate your valuable time and energy to teaching us. And understanding if those efforts translate into retained knowledge and better outcomes is certainly relevant for you. Additionally, health professionals spend on average 1 to 3 weeks per year at educational meetings. And making sure those courses are taught in an effective manner and are a valuable use of your time is also to your benefit. And what we will discuss today could also apply to those settings. And finally, the demands of practicing medicine are changing, and the amount of information one needs to know seems to persistently expand at a seemingly exponential rate. And we need to be able to prepare physicians to tackle new clinical challenges. And with these changing demands, pedagogical approaches are evolving, and improving our teaching practices for adult learners is imperative to training effective physicians. Where did the lecture begin? Well, the history of the lecture in medical education may date back to the very start of medicine itself, with Hippocrates in the 5th century BC. He has been depicted lecturing to students as seen here. Galen, a physician and philosopher in the time of the Roman Empire in the 2nd century CE, was also known to deliver public lectures. At this time, though, the predominant form of medical education was apprenticeship. With the establishment of medical schools in the 9th century CE, apprenticeship became an impractical method of education given the high student to faculty ratios, and lectures took on a more prominent role and involved students passively absorbing information read aloud and interpreted by the instructor. The lecture has, for centuries since, remained the foundation of and a central component to undergraduate and postgraduate medical education, given its efficient delivery of information. Early on, education via lectures was necessitated by a lack of resources as well, such as books and other reference materials. And they also served as an effective way to accomplish the basic transfer of information from instructor to pupil, given the relative lack of medical information compared to modern times. But even early on, the educational value of the lecture was questioned. In antiquity, as we mentioned, medical training was largely informal and based on apprenticeship. And Galen himself described an apprenticeship model consisting of extensive reading, clinical exposure, dissection, and dialogue between instructor and pupil, as opposed to the monotonous transmission of knowledge from authority to pupil, as would have occurred in a lecture. And later, in 1898, the editor of the Philadelphia Medical Journal published a harsh criticism of didactic lectures in medical education, arguing the secret of instruction is to teach methods, not results, to teach by demonstration, not by dictum. William Osler, the preeminent physician of the 20th century, went as far as to denounce lecturers, commenting, "Superfluity of lecturing causes ischial bursitis," which I hope nobody gets today. But perhaps lectures are not all bad. Within neurology, Jean-Martin Charcot was widely revered for his theatrical approach to lecturing about neurological topics during his Tuesday lessons, incorporating patient demonstrations, works of art, and extensive personal observations. Evidence shows, however, that not everyone can be Charcot. A study by Levine and Foreman in 1973 evaluated knowledge retention of medical students entering their neurology clerkship. Authors chose 50 questions from the students' previous neuroscience course test and re-administered them prior to the start of their neurology clerkship. The chosen questions were felt to represent key concepts that the students were expected to retain at the end of their preclinical coursework. The minimum pass level of the test, as indicated by this line, was set at 63%. And nearly 2/3 of the students scored below this level, suggesting that lectures were not a sufficient way to ensure retention and transferability of clinically relevant facts in neurology. Several studies across multiple subspecialties since have found that noon conference attendance among trainees is not predictive of nor associated with better outcomes on clinical and knowledge-based performance assessments. In fact, there are few studies in the literature demonstrating improvement in in-training examination scores with lecture-based conference attendance. A retrospective study in emergency medicine residents found that attendance at noon didactics was not a significant predictor of in-training examination scores, and a similar study that was prospective in radiology residents found that residents who avoided conference were indistinguishable from those who attended conference in a wide range of clinical and knowledge-based performance assessments, including their in-training examination. This study was conducted in family medicine residents and evaluated short-term and long-term knowledge gains based on noon conference attendance. Faculty attended conference and wrote 3 multiple choice questions based on the conference's content. 2 of the questions were compiled into a test at the end of the month, and the 3rd question was reserved for a cumulative test at the end of the study period. No statistically significant correlation between conference attendance over the 6-month period and resident scores on the cumulative or in-training examination were seen. Only a relatively small effect on short-term knowledge acquisition was seen, and authors could not demonstrate any long-term effects on knowledge retention. Evidence suggests then that traditional lectures are not the most effective means of modifying behavior, increasing interest in a subject matter, sustaining engagement, or facilitating learning and knowledge retention. But these data should not be misinterpreted to suggest that resident conferences have no value. Residents who attend conference may choose to do so because they find the experience valuable, and because the way the information is delivered during conference matches their preferred learning style. So the question remains, do we need to improve resident didactics in a lecture format or fundamentally change them? And how do we most effectively deliver a large amount of information in an engaging environment that encourages critical thinking? And in particular, how do we do this in a time with ever-increasing demands on both resident and faculty time and a constantly growing body of knowledge that must be learned? To answer these questions, it helps to understand some basic principles of adult learning theory and how they apply to professional professional learners, and in particular, residents. Adult learning theory was first introduced in the US by Malcolm Knowles in the early 1970s. He considered that adults learn differently from children and introduced the term andragogy to differentiate adult learning from pedagogy. There are several guiding principles of adult learning: relevance, goal orientation, self-directedness, readiness, internal motivation, and implementation of life experiences. Essentially, adults learn best when they know why they need to learn something, when they can use self-directed learning, when the learning involves real-life situations, and when the stimulus for learning is internal rather than external. There are several teaching approaches based on the principles of adult learning theory. A behaviorist approach, which is a teacher-centered approach in which the educator manipulates the environment to elicit a specific response from the learner, is ideal for teaching a new procedural skill. While a cognitivist approach, in which the teacher helps the learner develop effective self-directed learning skills and critical thinking through reflection, may be best for learning clinical problem-solving skills. The humanist paradigm focuses on learning as a personal act and developing the learner's autonomy. Problem-based learning and practice exercises are rooted in this approach. Social learning may be most well known to us and involves learning that is embedded in interactions with and observations of others in a social context, such as role modeling by master clinicians and teaching with case studies. Ultimately, adult learning theory means acquiring knowledge and skills and having them readily available from memory to make sense of future problems and opportunities. In other words, rather than rote memorization and passive acquisition of knowledge, information must be learned and stored such that it can be applied to a new situation in the future. And this is indeed a key skill in medicine. David Kolb in 1984 proposed an experiential learning cycle consisting of 4 components occurring in a cyclical fashion: concrete experience, reflective observation, in which the learner acknowledges what went well and identifies areas for improvement; abstract conceptualization, where the learner integrates information to form new hypotheses or generate a new approach; and then active experimentation, where the learner applies his or her new understanding in practice. According to Kolb and other learning theorists, observation, reflection, and application are crucial to the learning process. And as you can imagine, these components of learning are difficult to achieve with a traditional didactic lecture. So to summarize, successful learning requires multiple processes, including cognitive, affective emotional, motivational, social, environmental, and metacognitive domains. Based on adult learning theory, learning is deeper and more durable when it's effortful. Retrieval practice, such as a simple quiz after reading a text or hearing a lecture, is more effective than rereading the text or reviewing lecture notes. Learning is an iterative process that requires revisiting what one has learned, continually updating one's knowledge and connecting it with new knowledge. And mastery is based in trying to solve a problem before being taught the solution. Based on these principles, lectures serve as a difficult means in which to incorporate these strategies, and traditional didactic lectures have not kept pace with the changes to the educational environment and advances in learning theory. There have been several studies implementing the principles of adult learning theory in postgraduate medical education. In neurology, educators at Mount Sinai's residency program studied the utility of a new curricular design founded in these principles. Prior to the study, didactics consisted of 60-minute sessions that were shaped by the faculty's experience and preferences. During the study, they implemented 3 adult learning theory-based interventions: didactic reform, enhancing residents' teaching roles, and increasing resident engagement in educational activities. And they then compared resident performance on the right exam before and after the intervention. They found a significant increase in the proportion of residents with advanced performance and a corresponding reduction in average or poor performance on the right exam after implementation of the new curriculum. A longer duration of exposure to the new curriculum was also associated with higher right scores. Residents also expressed increased motivation and satisfaction on informal surveys with regards to the didactic reform. Of note, there were no additional costs to the department, and total didactic time did not change with the intervention. Another study conducted in neurology residents looked at the effect of 2 different educational interventions on right performance. The first intervention involved resident-prepared weekly neuropharmacology presentations, followed by weekly written quizzes. The second intervention involved resident-prepared weekly neuroanatomy presentations, followed by oral quizzes given in a game show format, with the winning team at the end of the course being offered a paid day off. A pre-test and a post-test was also given to monitor resident learning. Authors found no association between average written quiz scores and neuropharmacology subset percent scores on the right, but there was improvement in neuroanatomy subset scores, as well as scores on the administered post-test, showing that a team-based format may be able to improve learning. Authors also felt that the residents were held accountable by their peers and that this contributed to improvement in outcomes as well. It's also unclear how much a paid day off may have contributed to the results. They found additional unmeasurable benefits of the neuroanatomy intervention, including high energy and a positive learning environment, and increased self-study among the residents, as well as a cultural shift in which the residents formed study groups. A study at the University of Pittsburgh's internal medicine residency program looked at an interactive teaching format versus standard lecture on 4 cardiology topics. Each faculty member gave both a traditional lecture and an active format lecture on their topic. Residents' initial knowledge achievement and satisfaction with engagement were both higher in the active teaching format group, and the format did not cause an increase in stress for learners, and faculty also found the format enjoyable. Studies have also looked at other interactive formats, including small group teaching sessions. This is data from a meta-analysis of randomized controlled trials examining the effects of seminar teaching versus lecture-based learning in medical students. In a seminar-style didactic, learners are required to take ownership over their own learning and conduct pre-course work. These forest plots show that seminars outperformed lecture-based learning in every measured outcome except for mastery of basic concepts. Outcomes included improvement in classroom atmosphere, improvement of active learning ability, improvement of learning interest, cultivation of clinical thinking ability, and development of independent thinking ability. Other studies have similarly demonstrated enhanced competency with small group discussion-based learning over traditional lectures. Some of the small group or interactive lecture styles that have been used successfully in medical education are illustrated here. The flipped classroom down in the bottom left corner involves pre-work by the student followed by an interactive and reflective group discussion. This model may be effective for neurophysiology learning, for example, in which residents can watch instructive videos and then apply that knowledge later on an EEG rotation. This has been effectively studied in residents and showed improved medical knowledge. It does require, however, significant upfront investment. Multiple studies have also demonstrated superior efficacy of problem-based learning, seen here in the top right, over traditional lectures. And this approach incorporates many of the learning processes outlined by Kolb. It does, however, require increased faculty involvement due to the small group sizes. And finally, team-based learning, down in the bottom right here, uses many of the advantages of PBL, but with a smaller degree of faculty involvement due to the larger group. Another way educators have strived to make lectures interactive is through audience response systems, in which students have clickers that they can use to answer questions and participate in the lecture. Other examples of audience response systems are what we tried to use today, which failed me, unfortunately, which was Poll Everywhere. And positive responses to audience response systems by participants have not consistently translated into an increase in knowledge gain when objectively assessed. Research on the effectiveness of audience response systems on knowledge gain is limited and results are variable. Some studies suggest improvement in knowledge acquisition and others have shown no difference. It may be that an audience response system is not what's important, but rather simply including questions within the lecture is what matters. This study by Stoddard and Piquet looked to see if audience response system used by medical students was associated with improved performance on a course exam, in comparison to students who heard the same lecture with the same slides and the same questions, but without the use of an audience response system. Again, the only factors on which the lectures differed was whether the students were required to pick up their clickers to register an answer and whether they were able to observe how their classmates had answered through the audience response system. No significant difference in the percentage of correct answers on the exam, regardless of whether the students used the audience response system or not, was seen. And previous studies that found improved performance with audience response system use may have captured the effect of simply adding exam style questions into lectures rather than actually capturing the effect of using an audience response system. We have tried to incorporate some adult learning theory-based changes to our residency didactics this year here in Duke Neurology's residency program, including instituting a new fully question-based series of write reviews, optional pre-reading ahead of many noon conferences, and incorporating questions into most lectures to increase engagement and knowledge retention. And while this wasn't a randomized trial or a formal study, we did see an increase in write scores this year as a program. Overall, the program percentile is seen here in blue, and we achieved the 90th percentile this year as a program, which was the highest since we started recording data around 2014. And you can see our PGY3s in gray and PGY4 class in yellow, and they individually scored in the 95th and 92nd percentiles respectively. These results are likely, at least in part, attributable to these and other curricular changes that have been made over the past few years, but are also certainly a testament to the hard work by all of the residents and the faculty. One other change we made was instituting an advanced curriculum for PGY4 residents. This was a unique didactic program that we're not aware exists at any other residency program. It consisted of small group, case-based interactive sessions for PGY4 residents led by a faculty member. Sessions focused on rare diagnoses and advanced management decisions with the goal of preparing chief residents for independent practice. Some of the topics covered so far have included advanced management of MS, NMO, and other rare neuroimmunologic disorders, pregnancy and stroke, and the workup and management of rare movement and neuromuscular disorders. We recently sent out a survey to participating residents and faculty, and we haven't analyzed this data yet. So here's just some raw data from the survey filled out by the chiefs. But out of a maximum score of 10, on average, chiefs rated their level of engagement in a traditional lecture 2.75 versus 9 in the advanced curriculum sessions. And there was also a trend towards a feeling of increased preparedness for independent practice with the advanced curriculum sessions. What other measures can we look at, though, to know that interactive lecturing has a meaningful impact? This data is from a meta-analysis of RCTs on the effect of interactive CME on professional practice and healthcare outcomes. The few studies in this review that evaluated didactic presentations alone did not show an effect on professional practice. Studies that use small group discussion and practice sessions were more likely to improve physician practice. Ultimately, just because a teacher has presented information does not mean that a student has learned it. An acquisition of new facts does not necessarily guarantee better physician performance. How the physician translates this knowledge into action, that is, better patient care, is what matters. And these studies suggest that an interactive case-based approach may actually help to elicit a change in practice habits. There are several limitations to these studies, and there are some challenges to implementing changes to residency curriculums as well. As we discussed earlier, flipped classroom and PBL require significant upfront investment by both educators and learners. Some of this can be mitigated by using resources already available through other educational platforms and limiting the amount of pre-work that's required of students prior to the sessions. A disadvantage of small group discussions in TBL is that these discussions cannot be standardized or controlled by the instructor. And also the ideal group size for the most effective learning is not known. Another limitation in our knowledge is that we don't really know what learners value in their educational offerings. Few studies have evaluated what changes are most effective and meaningful for learners. A study by Swatsky and colleagues examined the perspectives of internal medicine residents toward their lectures and didactics and found that while residents felt engaged when the lecture required active participation, stress levels were elevated among learners who did not perceive a safe learning environment. And in general, residents found that lectures focused on clinical reasoning and clear applicable learning points were the most useful. To my knowledge, there are no studies examining this among neurology residents. And what residents value is central to the success of any didactic change. As part of my fellowship, I'll be pursuing a master's of medical education and conducting a study using an appreciative inquiry approach to determine what residents value in their educational offerings so that this knowledge can be used to develop and implement effective didactic techniques that mirror those values. Appreciative inquiry offers a unique approach with which to meaningfully innovate medical education. It uses affirmation, appreciation, and positive dialogue to change practices and meet the specific needs of an organization. It consists of 5 phases: define, discovery, dream, design, and deliver. The discovery phase focuses on valuing the best of what is or has been. and will involve individual semi-structured face-to-face interviews with neurology residents. The dream phase builds upon the insight gained in the discovery phase and explores what could be. This phase usually involves asking miracle questions in which the participants are compelled to imagine a miracle occurred and articulate what this perfect environment would look like. In the design and delivery phases, curriculum and didactic changes are conceived and ultimately implemented. Appreciative inquiry has been applied in both educational and medical settings with success. However, it's still likely underutilized in formal postgraduate medical education and can offer a rich perspective for effecting profound change. So I really hope that we'll gain some valuable insight from this study. So, is the lecture dead? If lecture refers to the traditional concept of a professor in front of a large group of students passively absorbing information, then yes, evidence supports that this approach should largely be lost to history. But if it describes interactive sessions that encourage self-study with frequent questions and an approach that emphasizes real-world experience and an application of knowledge, then the lecture may still have a bright future ahead of it. Education must transcend passing board scores, though, and lead to effective delivery of patient care. And applying adult learning theory to medical education requires changes on part of both educators and learners. Based on the literature, what are some techniques we can incorporate into our lectures? Big sweeping changes are likely not necessary, and making small adjustments to lectures can be effective. Begin by emphasizing the relevance of the subject matter. Use a case-based approach. Incorporate practice questions and quizzes. Emphasize clinical reasoning and immediate reflection and feedback, and keep lectures interactive. I'd like to thank everyone for listening, and I'd just like to thank everyone in the neurology program, especially program leadership, including Dr. Eckstein and Dr. Suma Shah, for supporting all the educational changes that we have tried to institute this year, and for their teaching and mentorship and help preparing this talk, as well as the rest of our faculty and the other chiefs without whom I would not have gotten through the past 4 years. And I would now be happy to take any questions or hear if anyone has any other thoughts on the topic. And I can see there's a lot of comments in the chat as well now.
Thanks, Ariel. That was actually wonderful. Very thoughtful. And I hadn't realized you had made so many changes to the noon lecture series, and that's really to be congratulated. Shri, do you want to start off? Anyone who has a question, just put their name in the comment section or the question, and we'll get to you. Shri, why don't you take it away?
Hi, good morning, Ariel. Really a fantastic talk. Great job. Thank you so much. And also, I was also not aware about all these changes made in the didactic session, so that was really helpful. I really support the idea of inquiry-based learning and interactive teaching session. But I think what I've seen is a lot of time when especially clinician educators stumble is how to do this inquiry-based learning without putting the learners, especially medical students or trainees in their early year, under undue stress, and without making them feel that the idea of inquiry or questioning is to make them feel that they don't know something. So do you have any tips about how to do it more effectively?
Yeah, I think that's a really great question, because I think creating that safe environment where learners feel comfortable both asking questions and answering questions potentially with the wrong answer is okay. And so I think one thing that I really like that I think actually I picked up from Dr. Hernandez this year is that when he gives a talk and asks questions, he mentions that he only knows the answers because he's the one asking the questions, or because he's the one who made the slides. And I find that to be really helpful, is to be humble and know that you kind of admit that you didn't know everything at the start either. I also really like to encourage learners to say, I don't know, because I think that especially in medicine, admitting you don't know something is just as important as knowing what you know. And that when you don't know what you don't know, that's when patients can get hurt. And so saying, I don't know, I think is a skill in and of itself. And so I think if we are sort of humble at the start and we say that and we create that sort of safe environment to not know something, learning can be a lot more effective.
Great, thank you.
So Ariel, so you took on the lecture. What about rounds as a teaching vehicle? Do you want to comment on them?
Sure. I think bedside teaching or teaching on the fly is certainly very different than teaching in a more formal didactic format. But I think the best ways actually to clinically teach is certainly at the bedside. And one of the methods I really like is called the 1-minute preceptor, where if a resident or a medical student, for example, presents a patient, you kind of have a very brief amount of time to teach when you're running around on rounds. And so you can basically use whatever they said as jumping off ground to teach clinical points. And if, for example, they're presenting a patient and the patient sounds really sick, you can walk with them to the bedside and ask them questions based on that patient's presentation. What would you, if you're worried about ICP, for example, what would you expect, or what are the signs of increased ICP? What are you expecting to see on exam? And kind of jump off of there and ask questions there, and you can get a lot accomplished just by teaching based off what the students have already mentioned themselves. And I think those are really good opportunities. And of course, sort of watching exams get done by senior attendings or other clinicians is also really valuable learning, and just incorporating your learners into that, having not just demonstrating the skills, but having them participate in the exam with you.
Len, you have a question?
Yes, thank you so much, Dr. Lefland, for summarizing the evidence on this topic and for sharing your analysis and your future plans. It's all very exciting. I'm wondering if you could say a little bit more about the experience over this past year with the programmatic changes that you and other chiefs have been implementing, particularly for the noon resident session. And I'm particularly curious about just what are the qualitative responses, comments, reactions from the residents themselves. And if you could speak to one particular issue, it seems very clear from the literature that high structure yields high learning outcomes at every level in adult learning. But the problem is, can our residents really bear that high structure? That's what's not clear to me. So that's one of the many questions in my mind about what you've learned in your experience this year. So could you maybe speak to some of those things, please?
Sure. So we've definitely been trying to kind of formally get a sense of what the residents have thought about some of these new curricular changes with the surveys that we sent out. Unfortunately, I haven't gone through all of those results yet, so I don't have objective information necessarily to share yet. But I think just hearing the residents talk, there's been overall a positive view of these changes and of making lectures more interactive. I think sometimes where residents struggle is that the day is already kind of long and hard, and adding additional time for didactics sometimes feels like a burden as well. And you kind of just want to take a break and turn your brain off for an hour. And so it becomes hard for residents to want to keep participating. And I think that's where the limitation is. And that's why we've tried to make lectures a bit more engaging and teach to different learning styles. I think the advantage of the advanced curriculum style as well is that we're able to teach to a specific level of learner. And I think that might be helpful. And this is certainly a challenge, I think, to implement in residency programs. But if there were a way to really teach to our different levels of residents, you might find that the residents are more engaged, more willing to participate, more willing to show up. I think one other aspect of adult learning that I didn't really have time to go over was cognitive load theory, where your working memory can only withhold so much information at a time. And when you've surpassed that information, your brain can quite literally feel too full. And so how we can combat that is another challenge. But what we don't know yet is actually how much information is too much information. We don't know what that limitation of cognitive load is. And so it's a little hard to use that to change didactics completely. Did that answer your question?
Yes, thank you so much.
Jordan suggests that we need a tree in the courtyard to teach under, which sounds good in the time of COVID. But Ariel, I mean, a lot of these studies use the right exam as an outcome. Is there any evidence the right exam predicts anything in terms of someone's career or?
It certainly has shown to be predictive of your performance on the boards, but I don't know if there's any data that shows it predicts your patient's outcomes or other measures of how you do as a physician. Those studies, though, shouldn't be misinterpreted either as a measure of how good the right exam is as a measure of clinical ability or clinical knowledge. Those studies weren't looking at the effectiveness of the exam as a tool, but just as the lecturers preparing people for those examinations.
Yeah, but no, I agree. You got to use the data you have, but we would like to know if those kind of didactics make someone a better chief resident, a better clinician. And I don't even know how you would assess that, but those are I mean, in surgeons, there are outcomes where how quickly someone can tie a knot, or how a certain manual skill is judged by their teachers and stuff. So there's something kind of practical that they can look at. I don't know if there's anything like that for us.
And I think one of the sort of hot topics in medical education as well is competency-based education, where there was this shift to trying to make these subjective measurements a little bit more objective. And I think those allow, and looking at milestones for residents allows for some formative feedback and allows attendings and faculty to sort of see residents more in the clinical setting, but I still think it's limited. And it's really hard for those aspects of clinical care that matter the most to make those into objective measures that we can grade residents on. It's still a challenge I think medical education is facing.
Suma, are you still out there? I saw that you had a question, I think.
Yeah, I was asking, kind of turning it back on Ariel, what would your miracle be if you wanted to design it for this residency program?
I think I agree with actually a lot of what the residents said earlier in terms of making everything case-based. I think that when you can apply the knowledge to a clinical scenario or make it applicable to a real life scenario, that's when it resonates with me the most and when I can remember it the most. And I have really felt that the advanced curriculum sessions this year have been really helpful. And it's also really nice to just be able to ask a faculty member, what would you do in this scenario? How would you approach this as well? And so if everything could be interactive, case-based, I think that would be great. I do think that sort of going back to that study about seminars, it's important to have a mastery of basic topics before you get to that though. And so I think there is still a role for didactics in other ways, but I think everything being case-based and sort of being short and sweet, that would be my sort of miracle scenario.
Nick?
Yeah, good morning, everyone. Thank you, Ariel, for a great presentation. It's an important reminder that we're always discussing having evidence-based practice in terms of what we do clinically, but we also need to do it in our education as well. So thanks for widening our view. And my question is a little bit similar to Suma's as well as, sort of our the lower hanging fruit, maybe more proximate goals, but you're working on a master's degree in education. I think that's very exciting, and that's not something everyone's doing. So I think we look to those with educational degrees for their expertise. But what do you think could be some next steps, for us here to do one more thing, or what have you found to be most helpful for you to take that next step towards applying this in practice?
That's a good question. I think, I'm not sure if this is an exact answer to your question, but I think one of the important things that I think is also happening on the faculty development side of things here at Duke is engaging faculty and engaging and teaching how to teach. I think that's really important too, because we can talk all day about changing resident didactics and wanting things to be case-based or interactive, but if we don't empower the faculty or sort of give them the tools to do that, that makes any curricular change difficult as well. And then I think, again, knowing what residents value, and this sort of comes back to Dr. O'Brien's point when Kristen was answering my question, is that it matters both what the residents prefer and what's objectively effective teaching, because we could change didactics all we want. And one of the other things we thought about doing this year was making sort of an online educational hub for the residents. And you can put hours and hours of effort into doing that. But if residents don't have the time and energy to access that, it doesn't matter how much effort you put into making it. And so I think that finding ways to ensure faculty have the tools to teach in an interactive format, and also the residents value it, and putting that together is really important.
So one thing I'm taking away for the department is that we should invest a little bit more in these kind of interactive modalities where the group can have their iPhone or their Google phone or whatever to answer questions as a group, as a way to kind of keep them engaged. Is that a good first start? And as a department, we should try to have an approved thing so that we're not always fumbling when we do things like that.
I think it's definitely a start. There are a lot of platforms out there for this. There's Kahoot, which is a way to ask questions sort of in a gamified way. There's things like Poll Everywhere and other websites out there that can be used to increase audience engagement in a talk. And so I think those would definitely be all valuable ways. There's always sort of a give and take, and there's research that suggests that if you gamify things too much, or you try to make things, almost too interactive, you'll lose some of your learners as well, who have a lot of internal motivation to learn and don't need all of that external motivation. So there's a balance that you need to strike, but I think that any way we can make things more interactive will be more engaging for adult learners.
And Brad, Brad makes a comment that's right on what you just said.
Yeah, it was funny. I was typing that in as you started to talk about gaming, and we had some folks, I don't know if Jeff Takeman jumped on, but from Anesthesia, he's been funded for years to try to develop educational simulation platforms for the military to make their medics more effective, at recognizing and treating conditions quickly, and putting in all the vitals and all of the reality of the situation into a gaming platform that's more flexible than, say, a mannequin, sitting on the table. So in your review, how does that fit in, and how effective are those strategies for providing these cases and letting people work through them? I as a guy who did EPIC in that, I find I'm still disappointed in the lack of feedback we get on our decisions. The pharmacy will throw out, hey, you're putting two drugs together, you really shouldn't. So it kind of prevents us from killing people, which is good. But it doesn't really tell you whether or not you're following like the best practice for epilepsy as you're ordering drugs for the outpatient clinic person who's got new onset seizures, right? So there isn't really an opportunity for it to feed back on your practice as you're performing it, or even afterward, comparing your patient return outcomes to, say, the national standards for something. So I think it would be interesting to know sort of those two things. Is there a role for more immediate feedback on practice, and can simulation or gaming help you with that?
I definitely think that reflective feedback is really important. And I think that is one of the principles of adult learning theory that should be applied to medicine more often. And comes back also to the Kolb cycle of experiential learning, is recognizing what went well, recognizing what needs to be done better. Having a person who can give you that feedback is of course needed, but being able to reflect on that your own is really important. And it should be timed well. It should be temporally related to when you saw the patient, right? So that you can make those changes and make them effective. In terms of simulation and gamification, I didn't read too much about this yet when preparing this talk, but I think that some of that data from the meta-analysis on CME used simulation, used small groups in that way, and found that in general, those were more effective than just a didactic-based lecture. And so I do think there's a lot of value in simulation if you have that master clinician, or you have someone who's an expert in what you're learning about, and they can give you formative feedback based on watching you in that situation. I do think that would be really helpful. And I think it would be of value, but I don't know the exact data behind it and what people have found so far in terms of how effective it is or how it changes outcomes in the end.
Ariel, is Zoom the disaster we think it is, or is it not? If you add Zoom to the noon lecture, what happens?
So I don't think so. I think certainly the COVID-19 pandemic turned education on its head a little bit, and people were forced to make dramatic changes in the way they deliver information to learners. But I think platforms like Zoom are actually really powerful tools if used the right way. it certainly allows for asking questions, keeping things interactive in both directions, both from the instructor to the pupil and in the opposite direction as well. Back to Dr. Shah's initial question, it can allow learners to feel comfortable asking questions because you can do so privately to the instructor via the chat if you don't feel like you are comfortable enough to ask the question in front of the entire group. And then there's also ways students can annotate the slides anonymously and participate that way. And so I think there's actually a lot of tools within Zoom. There's a virtual whiteboard as well. There's a lot of tools that we probably don't use very often or at all, might not even know exist through Zoom. And so I still think it's a really powerful platform if used well. I think Zoom also lends itself really well to things like flipped classroom, where students can watch videos or do other educational work ahead of the class, and then Zoom can be used as an interactive platform with discussion between students and the instructor. There's also breakout groups, so you could do smaller groups within a larger group. So I think there's actually a lot of great ways to use virtual learning. And it also has the advantage of allowing learners to learn from their own homes and make things more convenient for learners. And so I think it can actually work really well. And I don't think it's the end of good education.
All right, well, I think that's the end of the questions. That was quite an engaging bit of questions and answers for everyone. And I think it shows that there's a real gap in this area and a real desire to improve, but we often feel we don't know how, or I'm really old, can I really change? So yeah, thank you so much.
Thank you. Thanks, everybody.